It's kind of a three-part process. Number one is calculating how much fluid loss that patient has experienced based on percent dehydration and their body weight. There's a simple formula. You can calculate their fluid deficit. How fast we want to replace that deficit that patient has. If it's been an acute loss, we'll do a little bit of a faster replacement. If it's a more chronic loss, we'll do it a little bit longer, maybe over 2 or 3 days. So that's one facet of it. The next is that patient experiencing any ongoing losses? Are they still having frequent episodes of vomiting or diarrhea? Are they putting out too much urine and losing fluid that way? So whatever additional amounts of fluid they're losing, we need to replace that as well and calculate that into our fluid plan. And then the third part is their maintenance requirement. A lot of these patients that we have in hospital on fluids, especially when they're newly hospitalized, they're not eating or drinking yet, not taking in nutrition on their own, so we have to supplement that with what their daily maintenance requirements are. And then once we calculate all three of those, add them all up, and then that gives us a number in terms of mils per hour that they could be on. It's usually a very high number. We don't necessarily start there, but it's kind of a benchmark that if we feel like some of those perfusion parameters still are not being met, we can titrate up if we need to, and then as the patient is recovering, we can titrate it back down. So it's a multifaceted plan to come up with, but it's really, really important to determining patient outcome.